Welcome to the Rad-On Smart Review Head and Neck Cancer series.
Today we are undertaking a practical, board-relevant session focusing entirely on the oral cavity. This is really where the rubber meets the road in head and neck planning.
It really is.
We're going to zero in on subsite-specific contouring and, the clinical decision-making that governs whether we treat the neck ipsilaterally, bilaterally, and which nodal levels are mandatory.
Absolutely. Because you might walk into a clinic thinking oral cavity is just squamous cell carcinoma, levels 1 through 3, but the subtleties are they're massive.
They are.
And missing them leads directly to high-risk contralateral failure or, it's unacceptable toxicity.
Right.
So we're moving beyond those generic oral cavity rules to build accurate, defensible clinical target volumes, the nodal templates, the primary bed templates, for what are really 7 distinct regions.
That is our mission today. We are taking the oral cavity, which is so often treated monolithically, and breaking it into its constituent parts. So we're talking about the oral tongue, floor of mouth, buccal mucosa, retromolar trigone, lower gingiva, hard palate, and upper gingiva, and of course the lip. Each one is, anatomically and biologically, a completely different challenge.
Okay, so let's unpack this. I think a foundational review of the anatomy, epidemiology, and those key risk factors makes sense. We need to establish the red flags that immediately flip our decision matrix.
Sounds good.
So let's just start with a quick scope definition. When we say oral cavity, what exactly are we defining?
Okay, so we're defining the space from the vermilion border of the lip all the way back to the junction of the hard and soft palate above,
Right.
and then stopping at the circumvallate papillae of the tongue below.
And why is it so crucial to recognize those 7 distinct regions within that one space?
It's crucial because biologically, their underlying anatomy dictates their behavior. I mean, just think about it. The mobile oral tongue has this rich lymphatic supply that's just waiting to cross the midline.
Yeah, and a ton of soft tissue.
Exactly. And then you compare that to the hard palate, which has bone immediately beneath the mucosa. That's going to drive local invasion rather than deep infiltration.
Totally different patterns of spread.
Completely. If you confuse the floor of mouth with the buccal mucosa, you will contour the wrong nodal levels and completely miss the dominant extension pathways. It's a critical error.
So let's list them out again, just to be clear. We have the oral tongue, the floor of mouth, the buccal mucosa,
Retromolar trigone, the lower gingiva.
upper gingiva hard palate, and the mucosal lip. That's our checklist and histology here.
It's dominantly squamous cell carcinoma, and it's driven heavily by tobacco and alcohol exposure.
Which is an important piece of context, right?
It's vital context. Unlike the typically more favorable HPV-positive oropharynx, oral cavity SEC is usually a more aggressive, biologically challenging disease. It demands narrow margins and really aggressive local control.
Okay, so let's review the core drainage basins that apply to pretty much the entire oral cavity before we get into the subsite nuances.
Sure. The primary lymphatic drainage is consistently levels 1, 2, and 3.
The bread and butter.
Exactly. Level 1 includes the submental, which is 1A, and the submandibular 1B nodes.
Right.
Level 2 is the upper jugular chain, and level 3 is the mid-jugular chain. If you are treating the neck electively for oral cavity, this is what you're covering, especially levels 1 and 2.
Now, let's drill down on level 4A.
Yeah.
Because this is a really specific point of contention and, honestly, a critical board-relevant area. Why does the oral tongue, and really only the oral tongue, get this special consideration for elective level 4A coverage?
That's a great question because we generally try to avoid level 4A electively from most other oral cavity sites. We want to minimize morbidity, right? Especially to the apical parotid and the lower neck structures.
Of course.
The reasoning comes down to data and anatomy. The literature suggests that while, an isolated skip metastasis to level 4 is pretty uncommon in pooled node-negative data sets, the oral tongue, just by being so highly mobile and having these deep lymphatic pathways, has a distinct reputation. It drains further down the jugular chain earlier than, say, a buccal mucosa lesion.
So it's a known bad actor in that specific way.
It is, and level 4A, that anterior compartment of level 4, is considered the high-risk extension point if level 3 is involved or the disease burden is high.
Okay, so it's not a universal rule. It's more of a risk stratification. If the oral tongue tumor is aggressive, or if nodal disease is already confirmed, we extend to level 4A as a defensible measure against lower jugular failure.
Precisely. If we have a 2-centimeter deep oral tongue tumor with positive level 2 nodes, Ignoring level 4A would be a really high-risk planning decision.
Whereas,
Whereas if we have a superficial, well-lateralized buccal mucosa primary, level 4A is completely unnecessary elective volume.
okay, that makes sense. Let's transition to the key risk predictors, the red flags that immediately elevate the risk and force us into, say, bilateral coverage or expanded primary target volumes. You mentioned 3 core predictors.
The first, and I would argue the most crucial feature that distinguishes the behavior of oral cavity tumors, is the depth of invasion, or DOI.
Right, DOI. We see it referenced in millimeters on path reports.
Hmm.
Why is DOI such a consistent, strong predictor of not just local recurrence, but specifically of contralateral failure risk, even when the tumor looks lateralized?
DOI is the invisible enemy. That's how you should think of it. It tells us the true biological aggressiveness and the likelihood of lymphovascular space invasion, or LVSI, regardless of the size you measure on the surface.
So it's what's happening underneath.
Exactly. Once the tumor penetrates deeply, and the critical inflection point is often considered around 8 to 9 millimeters, it has access deeper, richer, and often cross-midline lymphatic channels that are functionally connected to the contralateral neck.
Okay.
The source material is clear that a substantial DOI, like a 9 millimeter lesion, is a consistent predictor of contralateral failure risk. The rule is simple. High DOI overrides superficial appearance.
That's a really critical piece of context.
Right.
So if the DOI is 9 millimeters, even if the primary is technically 2 centimeters from the midline, we have to treat it as a high-risk lesion.
You must.
So what's the second major flag?
Nodal disease. The presence of any positive node pathologic N1, N2, or N3 on the ipsilateral side elevates the contralateral risk significantly.
Why is that?
Well, if the disease has already demonstrated the ability to metastasize to the adjacent neck, the chances of microscopic disease crossing the midline, especially in those central subsites, just increase dramatically.
It's already proven it can travel.
It has. So positive nodal disease is typically a mandate for bilateral treatment unless the primary is extremely lateralized and superficial, which is a pretty rare scenario.
And the third flag relates to location. Midline proximity. We need an objective measure here. What is the board-defensible definition of well-lateralized?
We use the 1 centimeter rule. Well-lateralized means the primary tumor edge is 1 centimeter or more from the midline structure. If it is touching the midline or within 1 centimeter, it is functionally near midline. In this scenario, you must default to bilateral coverage because the cross-midline lymphatic drainage from the floor of mouth, anterior oral tongue, and hard palate is simply too high a risk to ignore.
This is the perfect moment to revisit that analogy we talked about, because these rules, DOI, nodal status, and midline, they really dictate the security system of our apartments.
Yes. We have to stop thinking of the oral cavity as a single room. Think of it as 7 distinct apartments.
Yeah.
Each apartment has a unique floor plan, which dictates the primary local drainage pathways, levels 1 and 2, or deeper structures. And each has shared walls with adjacent structures, which dictates the extension pathways, like the inferior alveolar nerve or the lymphatic midline.
I like that. So the oral tongue apartment is in a bustling central building. It's sharing critical walls with the opposite neck due to that high DOI risk, demanding high security bilateral coverage. Whereas the buccal mucosa apartment might be a lateral standalone unit, which could allow for ipsilateral treatment if the security system, the DOI and nodal status, comes back clean. This analogy really should guide every planning session.
It connects the anatomy to the clinical risk. Treating a floor of mouth lesion, which is a central apartment, with a high DO, I should immediately scream bilateral, regardless of how neatly the surgeon cut it out.
Okay, perfect.
Yeah.
So moving on to the practical workup, especially in the adjuvant setting where we're planning on a post-operative bed, the imaging imperatives are critical. We're trying to reconstruct the crime scene after the cleanup crew has left.
Absolutely. The foundational rule in post-operative planning is that you must use your CT simulation fused to the best available preoperative imaging.
Non-negotiable.
It's non-negotiable. We rely heavily on that diagnostic MRI, diagnostic CT, or diagnostic PET CT.
Why is that fusion so important? I mean, why can't we just look at the surgical cavity on the simulation CT?
Because the post-operative bed is dramatically altered by surgery. You have inflammation, fluid collections, and soft tissue flaps that just obscure the original tumor extent.
It's a mess.
It's a mess. You cannot accurately define the original tumor footprint, especially its deep margins into muscle or fat planes, without the preoperative MRI that mapped the gross tumor volume. We are essentially contouring the high-dose CTV based on the preoperative map combined with the postoperative anatomy.
So missing that fusion is just a cardinal planning error.
It absolutely is.
That preoperative map allows us to define the initial gross tumor volume, which then forms the core of our high-dose clinical target volume before we union it with the surgical bed.
Exactly. We need the preoperative footprint to know where the tumor started, the operative note to know where the surgeon went, and the pathology map to know where the margins were close. All three inputs define the high-risk CTV.
Let's discuss AJCC staging, specific to the oral cavity, focusing on the T&N implications that drive our decision-making. Starting with T category, what are the most critical T-stage modifiers we need to look for?
We're assessing for modifiers that indicate deep penetration or bone invasion. The key T-stage modifiers are mandibular invasion, involvement of the masticator space, or extension to the pterygoid plates. These features dramatically escalate the risk.
And how does the presence of those modifiers change the management paradigm?
They often define the inflection point between resectable and unresectable disease, which dictates whether we are planning adjuvant radiation or definitive chemoradiation.
Okay.
For instance, in retromolar trigony lesions, our gateway apartment involvement of the masticator space can sometimes render the disease functionally unresectable, even if it's technically stage T4A.
Which pushes you strongly toward definitive chemoradiation.
Exactly, combined with platinum chemotherapy.
So local extent can override the technical T stage if it compromises surgical feasibility, leading to a definitive treatment path. And something like mandibular invasion, which is common in lower gingiva, strongly dictates the need for post-operative radiation, even after a segmental mandibulectomy.
Right. Now let's turn to the N category and focus on the nuance surrounding the surgically dissected neck versus the undissected neck. This is often where residents can confuse the risk profile.
Okay, this is a great point. So if a patient undergoes a thorough selective neck dissection, say levels 1 through 3 are removed, and the pathologist confirms 0 out of 20 nodes are positive, that is an adequately dissected pathologic N0 neck.
Correct. The risk of residual microscopic disease in that specific neck is fundamentally different and much lower than in a neck that was clinically staged as N0 based only on imaging and physical exam. The surgical staging gives us confidence.
And why is this distinction so crucial for our radiation planning?
If the ipsilateral neck was surgically dissected and proven N0, and the primary tumor risk factors like DOI or margins are not overly aggressive, we might argue against elective treatment to that ipsilaterally dissected bed, depending on the T stage.
So we'd only be treating the primary bed high-dose CTV.
Potentially, yes. However, if the neck was clinically N0 but was not dissected, maybe a planned definitive radiation case that converts to adjuvant, then we absolutely must treat that undissected neck electively, respecting all the drainage pathways for that subsite. This distinction validates the upfront surgical staging.
In short, a surgically staged N0 neck has a lower security alert than an observation-only N0 neck.
That's a great way to put it.
Okay, so let's move to pathology. Beyond just confirming SCC, we're looking for the high-risk pathologic features that act as absolute triggers for adjuvant therapy and crucially determine our CTV margin design.
Right, and the primary triggers are pretty well established.
So what are the top 3 features reported by the pathologist that just fundamentally change our management?
First, we have margin status. While we always strive for clean margins, ideally 8 millimeters or greater, if the margin is positive or close, which is generally defined as less than 1 millimeter, that is an unequivocal mandate for postoperative radiation and often chemoradiation.
And even if margins are negative?
Even then, if other high-risk features like high DOI or PNI are present, we still proceed to adjuvant radiation.
Okay. Second is extranodal extension, or ENE. This is the powerhouse risk factor.
ENE is the most powerful predictor of recurrence risk. It is the classic mandatory driver for adding concurrent platinum-based chemotherapy to the adjuvant radiation regimen.
So when ENE is present, what is that confirming?
It confirms that the tumor cells have breached the lymph node capsule and are spreading into the surrounding fat. It's a sign of aggressive biology that requires systemic control.
Okay. The third major category is perineural invasion, or PNI. This is where the subsite-specific planning gets intensely detailed and can create massive CTV expansion needs.
It really can. PNI means the cancer is tracking along a nerve sheath, using it as a superhighway to escape the local area and head proximally toward the skull base.
Which means we have to follow it.
It dictates that we must follow the nerve pathway proximally, often for several centimeters, sometimes all the way to the major foramina in the skull, even if the primary CTV does not initially extend that far.
And PNI is highly subsite dependent because of the regional nerve supply.
Mm-hmm.
So let's elaborate on the V3 pathway, which is essential for the lower half of the oral cavity.
Right. For lower gingiva and floor of mouth, PNI often involves branches of the mandibular nerve, which is V3, specifically the inferior alveolar nerve in the mandible or the lingual nerve in the floor of mouth.
And if PNI is reported along these,
You cannot just treat the primary bed. You must include the entire at-risk V3 pathway.
that sounds like massive volume creep, especially tracking toward the skull base. You mentioned the foramen oval. For the listener, can you explain why tracking to the foramen oval is necessary and just how difficult it is to visualize?
It is challenging. The mandibular nerve, V3, exits the skull base through the foramen oval. If PNI is tracking along a V3 branch, there is a legitimate microscopic risk that the tumor cells have reached the main nerve trunk and are heading centrally.
So you have to be meticulous.
Meticulous. Tracking this pathway requires really careful contouring, often involving the entire masticator space, the pterygoid plates, and the bony structures leading up to the skull base. This relies heavily on MRI fusion to accurately delineate the nerve path and the foramen. We're talking about prophylactic coverage that can extend 5 to 10 centimeters from the primary tumor just to cover this microscopic track.
The justification must be solid to irradiate such a large critical volume. Is the evidence strong enough to justify treating the entire V3 pathway prophylactically, even if PNI is only microscopically present in the surgical specimen?
The evidence for definitive advanced PNI is very clear. Local failure rates are extremely high if the nerve path is ignored.
So you have to do it.
When PNI is reported, the implication is that the process is active, and the microscopic track is often longer than what the surgeon can see or remove. Therefore, in the setting of positive PNI in oral cavity SCC, covering the entire path to the skull base, such as V3 to the foramen ovale, is the widely accepted standard of care to prevent a painful, debilitating skull base recurrence.
And finally, a high-yield pathology pearl that is unique to the hard palate subsite and forces a similar decision on nerve pathway coverage: adenoid cystic carcinoma, or ACC.
This is a crucial distinction. Minor salivary gland malignancies like ACC are relatively common in the hard palate and upper gingiva.
And they behave differently.
Very differently. ACC has an inherent, central, and relentless propensity for perineural spread. It is part of its biological fingerprint.
So if the pathology report says ACC of the hard palate, even if it does not explicitly state PNI is present in the specimen, what must you consider including in your target volumes?
You must immediately cover the V2 pathway, the maxillary nerve, which runs through the pterygopalatine fossa and leads toward the skull base via the foramen rotundum.
Even without PNI on the report.
Even without it, because the perineural propensity is so central to ACC biology, prophylactic V2 nerve path coverage is often mandated. If you miss this, you set the patient up for an eventual devastating skull base recurrence, which is almost always incurable. This is a classic board-level trap. ACC equals automatic nerve path coverage.
Okay, wow. So we've established the high-risk features DOI, nodal disease, midline, and the nerve pathway risks with PNI and ACC. Now let's use those triggers to define our nodal treatment volume. Let's start with the master decision: ipsilateral versus bilateral neck coverage.
The core rule is built on risk mitigation. You default to bilateral coverage if any of the major red flags are raised. The primary lesion is midline or near midline, so less than 1 centimeter. It crosses midline, there is substantial DOI, so 8 millimeters or more, or if any nodal disease is present. These factors all significantly raise the probability of contralateral microscopic disease.
And when can we safely stick with ipsilateral treatment? When is that okay?
You default to ipsilateral coverage only if the lesion is truly well lateralized, the contralateral neck is clinically N0, and the overall biology is low risk, meaning superficial DOI, no PNI, and negative margins.
So everything has to be favorable.
Everything. We must acknowledge that ipsilateral radiation is defensible in properly selected, truly lateralized cases, particularly buccal mucosa, but the threshold for going bilateral in oral cavity SCC must be low.
Okay, let's use the if-then ladders and our apartment analogy to review the 7 subsites. Let's start with the oral tongue, the central mobile apartment.
The oral tongue is perhaps the most mobile, lymphatic-rich, and complex subsite. It is functionally a central structure. Core drainage is levels 1, 2, and 3.
And the risks here are that high mobility leading to cross-midline spread and DOI.
Exactly. Cross-midline drainage is common, and DOI is absolutely critical. A T2 lesion might look small, but if the DOI is high, we treat it as advanced disease biologically.
And we also pay special attention to level 4A here.
Yes. For the oral tongue, elective extension to level 4A is warranted when risk is elevated, meaning if there is substantial DOI or any nodal disease. This is the exception to the rule for the lower neck coverage in oral cavity SCC.
What's the high-yield if-then trigger for bilateral treatment?
If the oral tongue has substantial DOI, say 9 millimeters, or any nodal disease is present, then bilateral neck treatment is the default. Furthermore, if you encounter bulky level 2 disease, you must assess for posterior extension and consider elective level 4A coverage. We are treating the entire basin of risk.
Okay, next up, floor of mouth, the anatomically midline apartment.
The floor of mouth sits directly on the midline and is functionally near midline anatomy. You have to assume cross drainage. Drainage is levels 1 and 2. But due to its interior location, we must specifically emphasize coverage of bilateral level 1A, the submental nodes. They're the first relay station for anterior drainage. You cannot treat a floor of mouth lesion without hitting both level 1As.
And the local extension risk is high here. We're talking mandibular invasion and PNI along the lingual nerve.
Right. So the if-then, you must maintain a low threshold for bilateral necks with a floor of mouth primary due to its inherent midline nature. And if PNI is reported along the lingual nerve, you must track that specific pathway toward the skull base, the V3 pathway to the foramen oval, as we discussed earlier.
Makes sense. Okay, number 3, buccal mucosa, the isolated lateral apartment.
This is the lateral success story. If there is an oral cavity subsite that allows for confident ipsilateral treatment, it's often the buccal mucosa.
Right.
It is the cleanest subsite for ipsilateral treatment if the security check is clear. Well-lateralized and limited nodal disease. Drainage is typically levels 1 and 2.
But the special node consideration here is frequently missed by residents because it's often outside the standard neck dissection boundaries.
That's the facial or buccinator node region. These superficial cheek nodes can be the first site of metastasis for bulky anterior buccal lesions.
So you have to actively look for them.
You have to. If the primary is bulky, anterior, or if diagnostic imaging suggests potential nodes in the cheek, you must deliberately ensure your contour includes this region, which lies superficially over the mandible and masseter muscle outside level 1B.
So the if-then for buccal.
If buccal mucosa is truly well-lateralized and exhibits limited nodal disease, for example N1 without ENE, then ipsilateral neck treatment is acceptable, provided you assess for and include the facial node regions when clinically necessary.
Perfect. Let's move to a trickier one, the retromolar trigon, the gateway apartment.
The retromolar trigon, RMT, is the dangerous junction. It is the gateway because it provides immediate access to deep structures outside the oral cavity.
It sits right where the local extension pathways become most problematic. The masticator space, the pterygoid region, and the skull base. This is where we see local extent overriding surgical feasibility.
Absolutely. The RMT involvement of the masticator space is the classic feature that pushes a case toward unresectable or definitive chemoradiation. Drainage here is typically posterior, emphasizing levels 2 and 3.
So what's the crucial inflection point for management?
It's bone invasion. If the RMT lesion has mandibular cortical invasion, it usually mandates surgery, followed by post-operative RT. However, if we see deep involvement, pterygoid or masticator space involvement, the if-then is clear. If deep structural involvement is present, then treat the case like advanced, potentially unresectable disease, typically definitive chemoradiation, as the chance of clear surgical margins in those deep spaces just plummets.
Okay, that's a huge decision point. Next, lower gingiva or alveolar ridge, the bony apartment.
This subsite is intimately connected to the underlying bone, the mandible, and the nerves that run through it. Drainage is levels 1 and 2.
The major risks are high frequency of mandibular invasion, and therefore high risk for PNI along
The inferior alveolar nerve, which runs within the mandible body.
And PNI here means aggressive volume coverage.
Yes. If PNI involve the inferior alveolar nerve, then that necessitates coverage of the ipsilateral hemimandible region and tracking the V3 nerve pathway toward the foramen oval. Nodal coverage here can be ipsilateral if truly lateralized, but PNI risk usually expands the volume significantly.
Okay. Number 6, hard palate and upper gingiva, the specialized histology apartment.
These subsites are generally less about nodal risk, which is often levels 1 and 2, and more about local invasion into the maxillary sinus or nasal cavity and the histology.
And this brings us back to that pathology pearl.
It does.
Yeah.
If the pathology report identifies adenoid cystic carcinoma, ACC, which is common here, then you must automatically cover the V2 pathway, the maxillary nerve, toward the foramen rotundum at the skull base, regardless of the explicit P&I status. This is the non-negotiable coverage rule for the palate.
Got it. And finally, in number 7, mucosal lip, the superficial apartment.
Right. We're focusing on SCC, starting at the wet-dry junction of the mucosal lip. This is distinct from cutaneous lip cancer.
And the drainage is pretty localized and predictable, right?
Yeah.
Primarily level 1.
It is. Nodal management is largely dictated by T stage and is often conservative. If the tumor is T1 to T2 and clinically N0, observation of the neck is commonly acceptable.
But if it's larger?
If the tumor is T3 or higher, then we must consider elective nodal coverage, starting with level 1 and expanding as risk dictates.
That provides a really comprehensive set of rules. We can summarize the default risk profile. Oral tongue, floor of mouth, and hard palate all demand a low threshold for bilateral treatment.
And buccal mucosa is our best shot for ipsilateral. It's the synthesis that protects the patient. Using this subsite-specific approach prevents you from undertreating a central, deep lesion while also avoiding unnecessary bilateral toxicity for a peripheral, shallow lesion.
Okay, let's shift now from the biological and anatomical rules to the practical application at the treatment planning workstation. Since there isn't a single randomized trial that dictates HNC contouring rules, we rely on pooled evidence and the modern post-operative framework. Let's detail the practical 4-step contouring workflow for the primary bed CTV.
The workflow requires precision and the integration of multiple data sources, which is why that fusion imaging is step 1.
Right, so step 1, initial assessment.
You start by gathering all necessary data. The diagnostic imaging, so your MRI, CT, or PET-CT, the surgeon's operative note, and the pathologist's map of the specimen, noting tumor footprint, close margins, and any nerve or bone invasion. This gives you the preoperative extent.
Okay, then step 2, defining the surgical and reconstruction bed.
You contour the actual surgical bed visible on the CT simulation. If a free flap or regional flap was used, you must contour the entire volume of that reconstruction pathway.
And why is that?
Because these are planes of surgical manipulation, edema, and potential microscopic scatter. They are considered areas of high risk for recurrence.
Okay. Step 3, building the primary CTV footprint.
Now, we build the CTV. We take the preoperative footprint of the disease, the area where the GTV was, and we expand it by approximately 1 centimeter.
Yeah.
We then take the union of that expanded footprint with the contoured surgical and reconstruction bed volume. That is your initial CTV.
And finally, step 4, editing for anatomic barriers. This is the de Hansa concept.
This is critical. The resulting initial CTV is often way too large because a simple, uniform expansion ignores anatomy. We must edit the contour, respecting the anatomic barriers and compartments that the tumor was highly unlikely to cross.
So you're carving it back.
Exactly. The de Hansa concept heavily influences this by reminding us to exclude bone, cartilage, or fascial planes that were not pathologically involved or surgically transgressed. This gives you a reliable, defensible, and safer final high-dose CTV.
So we're not just drawing a balloon around the cavity, we're using the fusion image and anatomical knowledge to sculpt the CTV, excluding low-risk areas.
Exactly right. Blind expansion leads to unnecessary toxicity. Anatomically informed editing leads to a precise CTV, which is paramount in the oral cavity due to the proximity of the mandible.
And this entire framework really relies on the principle we discussed earlier, the inherent value of surgical staging. Can you just reiterate why an adequately dissected pathologic N0 neck has a different lower risk profile than an undissected N0 neck?
Sure. When a neck dissection is performed and comes back N0, we have physically removed the most common lymphatic relay stations, levels 1, 2, 3, and confirmed they contain no cancer. Therefore, our primary focus shifts almost entirely to the primary bed. We worry less about microscopic disease in the electively treated areas because those nodes have been removed.
And conversely, if no dissection was performed, we assume the lymphatic pathways are intact and potentially harbor occult disease, forcing us to irradiate the entire elective nodal chain, often to 44 or 50 gray. Okay, let's apply this comprehensive framework to a real-world scenario. Let's return to our mini-clinical case, the high-risk oral tongue.
Right. Case 1. A 61-year-old woman with a pathologic T2, pathologic N1, right lateral oral tongue, SCC. Key facts. DOI was 9 millimeters, there were 2 positive level 2 nodes, margins were negative, and there was no ENE.
The decision matrix flips immediately here due to the combination of high DOI and positive nodal disease. This demands bilateral coverage, even though the primary was called lateral. So how would you dictate the dose and volume prescription using IMRT or VMAT design?
Given the positive nodes and high DOI, this is a clear case for high-risk adjuvant radiation. I would prescribe. First, the CTV 60 gray primary bed. This covers the high-risk region, the surgical bed, and the 1 centimeter expanded preoperative footprint using anatomical editing. This addresses the highest local recurrence risk.
Yeah.
Second, the CTV nodal intermediate dose. This typically targets the involved nodal bed, so right level 2, plus the adjacent at-risk levels, right level 1 and level 3, treating them to an intermediate dose, generally around 54 to 57 gray. This addresses residual microscopic disease in the involved side.
And the contralateral neck.
Third, the CTV elective dose. This is the mandate driven by the DOI and N1 status. We would treat the contralateral clinically N0 neck electively. This volume includes levels 1, 2, and 3. Crucially, given that this is an oral tongue primary with high-risk features, we would maintain a low threshold to include level 4A in the elective volume. This elective volume typically receives around 44 to 50 gray.
That plan maximizes coverage of the highest risk regions while addressing the contralateral neck threat. Now, we have to talk about the dominant late toxicity in oral cavity radiation, osteoradionecrosis, or ORN. This is often the constraint that determines whether a plan is actually deliverable.
ORN is the toxicity we try hardest to mitigate because it is debilitating and often requires significant intervention, even surgery. The core difficulty is that the primary CTV in many oral cavity subsites is sitting directly against the mandible.
And the subsite location dictates which part of the mandible is most vulnerable, which informs our contouring and planning goals.
Absolutely. For oral tongue and floor of mouth, the central and anterior subsites, the anterior mandible body is commonly in the high-dose zone.
Right.
For buccal mucosa, the lateral subsite, the lateral body, and ramus are at risk. And for retromolar, trigone, and lower gingiva, the posterior subsites, we worry about the posterior mandible and ramus. If the mandible is not invaded, our goal is to keep the dose away from the bone as much as possible.
So what are the practical DVH constraints that serve as anchors for risk mitigation in a non-invaded mandible?
While constraints can vary slightly, a widely referenced practical DVH anchor from IMRT cohorts suggests aiming for the mandible V44 under roughly 42% and the V58 under roughly 25%. Achieving these goals, particularly keeping the high-dose coverage, that V58 low, has been consistently associated with a lower ORN risk. Of course, if there is gross bone invasion, these constraints become secondary, and you must counsel the patient heavily about the necessary high dose to the bone.
Right. Okay, so unlike oropharynx, where trials constantly challenge de-escalation, in oral cavity, the controversies often center around clinical judgment and avoiding critical planning traps where established rules are ignored. What are the 3 highest yield mistakes or traps residents must avoid, especially when planning for the board exam?
These are the traps that lead to preventable failure. Trap 1. Ignoring the biological risk of the oral tongue.
So what does that look like?
Treating a high-risk oral tongue one with substantial DOI or positive nodal disease with ipsilateral neck only because the surgeon said the primary was lateral.
Yeah.
You cannot ignore DOI and N status. They are paramount.
Okay, trap 2.
Trap 2. Forgetting level 4A in high-risk oral tongue. Missing level 4A entirely in a high-risk oral tongue case. While we don't treat level 4A for all N0 oral cavity cases, the literature strongly supports its elective inclusion specifically in the oral tongue when risk is elevated due to N status, or DOI.
And the third one.
Trap 3. Missing the facial nodes in buccal mucosa. Treating buccal mucosa without actively assessing for and contouring the at-risk facial or buccinator node regions when the clinical scenario dictates it. You cannot assume a standard level 1B contour covers those superficial cheek nodes.
To help cement the rules for bilateral coverage, let's use the mnemonic we introduced for the 3 subsites that, due to anatomy or high-risk features, mandate a low threshold for bilateral treatment.
That is TFP for mandatory low threshold for bilateral nodal coverage.
Okay, so T stands for tongue. Oral tongue due to DOI and mobility. F stands for floor. Floor of mouth due to functional midline anatomy and anterior drainage, specifically level 1A. And P stands for palate. Hard palate due to midline anatomy and histology risk, specifically ACC, which dictates bilateral V2 coverage. TFP are your default bilateral sites.
Exactly.
Okay, let's put this detailed knowledge into practice with 4 oral board-style questions. First question, on the oral tongue contralateral neck.
Let's do it.
A 55-year-old man has a T2N0 squamous cell carcinoma of the right lateral oral tongue with a DOI of 8 millimeters. He undergoes partial glossectomy with right selective neck dissection. Pathology shows negative margins and 0 of 19 nodes positive. Which statement is most board-appropriate regarding the contralateral neck? A. Contralateral neck irradiation is never indicated in a clinically node-negative oral tongue cancer if the tumor is lateral. B. Contralateral neck management depends on risk features like DOI and midline proximity, and bilateral elective treatment is reasonable when risk is elevated. C. Contralateral neck should always be surgically dissected regardless of tumor features. Or D. Contralateral neck is only treated if ipsilateral extranodal extension is present.
The best answer is B.
Okay, tell us the rationale.
Option B reflects the necessary nuance. Since the risk of contralateral failure rises consistently with DOI and 8 millimeters substantial, bilateral elective coverage is the most defensible choice here, even with a pathologically N0 ipsilateral neck. We are prioritizing biological risk over anatomical appearance.
Perfect. Question 2. Buccal mucosa coverage. A 63-year-old woman has a T3N1 squamous cell carcinoma of the left buccal mucosa, well lateralized at 2 centimeters from midline. She undergoes wide local excision and left selective neck dissection. Pathology shows 1 of 18 nodes positive in level 2 without ENE. What is the most appropriate general approach to neck coverage? A. Bilateral levels 1 through 4 for all buccal mucosa cancers. B. Ipsilateral neck irradiation is acceptable in properly selected well-lateralized cases with attention to facial or buccinator node regions when indicated. C. Observe the neck because only 1 node was positive. Or D. Treat ipsilateral levels 1 and 2 only and never consider additional at-risk nodal regions.
The best answer is B.
And the rationale there.
Well, buccal mucosa is our low-risk subsite. A well-lateralized T3N1 without ENE can often be adequately managed with ipsilateral adjuvant radiation as the contralateral risk is low. However, the T3 stage and the subsite location mandate that we specifically check and potentially include the facial and buccinator nodes.
Got it. Question 3. On the retromolar trigone inflection point. A retromolar trigone tumor is stage T2N0. Imaging shows no mandibular invasion and there is no masticator space or pterygoid plate involvement. What feature, if present, would most strongly push you toward surgery plus post-operative radiation rather than definitive radiation? A. Tumor is lateralized. B. Mandibular cortical invasion. C. Patient is a former smoker. Or D. Tumor is 2 centimeters rather than 1 centimeter.
The correct answer is B.
Why is that inflection point so important in RMT?
Because bone invasion, particularly mandibular cortical invasion, dramatically changes the management and prognostic calculus. In resectable RMT disease, bone involvement strongly favors the addition of surgery followed by post-operative radiation.
Okay, last one. Question 4. A contouring question. Scenario. You are planning a post-operative CTV for a floor of mouth SCC that tracked along the lingual nerve. What specific pathway must be included in the contouring, even if it extends far from the primary bed? A. The V2 pathway toward the foramen rotundum. B. The V3 pathway toward the skull base. C. The anterior facial artery pathway. Or D. The hypoglossal nerve pathway.
The correct answer is B.
Rationale.
PNI involving the lingual nerve, which is a branch of the mandibular nerve mandates, covering the V3 nerve pathway coverage, tracking all the way proximally toward the foramen oval at the skull base.
Perfect. Let's synthesize these detailed rules into 3 high-yield clinical pearls for you to take to the workstation. Pearl number 1.
Okay.
The risk of contralateral failure in oral cavity is heavily dependent on DOI and overall nodal burden, regardless of how neatly the primary tumor was excised. Remember, DOI 9 millimeters plus N1 disease is functionally a bilateral disease.
And the context here is protection. This is why level 4 coverage in a high-risk oral tongue case is often defensible. It provides a safety net against known patterns of deeper drainage that is not required in other lower-risk oral cavity subsites.
Pearl number 2. Retromolar trigone involvement of the masticator space or pterygoid plates defines the major inflection point in management for that subsite. It immediately pushes the treatment path toward unresectable disease and definitive chemoradiation.
The context here is feasibility. When local extent compromises surgical margins in these deep, unforgiving spaces, the management shifts from adjuvant to definitive, emphasizing maximal local dose and systemic control.
And pearl number 3. Always check the pathology for minor salivary histology, specifically adenoid cystic carcinoma, in the hard palate and upper gingiva. This diagnosis automatically triggers the need for nerve pathway coverage, specifically the V2 pathway, even if the pathologist doesn't explicitly report PNI.
And the context is biology. Paraneural propensity is inherent to ACC. If that histology is present, you must prophylactically cover the path to the skull base to prevent an eventual painful recurrence along the nerve sheath.
Okay, to bring this comprehensive session together, let's just remember the synthesis of our subsite rules and that TFP mnemonic.
The high-risk subsites oral tongue, floor of mouth, and hard palate require a low threshold for bilateral neck coverage due to midline access, deep DO iris, or aggressive histology like ACC.
And the buccal mucosa is your preferred site for ipsilateral treatment, provided it is truly well-lateralized and low risk, but you have to actively look for and contour the facial or buccinator nodes when the clinical T-stage is bulky.
And finally, precision contouring requires fusion imaging and respecting the neural highways. If paraneural invasion is present in the lower gingiva or floor of mouth, you must track the inferior alveolar or lingual nerve paths, meaning coverage of the V3 pathway toward the foramen oval.
We've provided the framework for building a defensible plan, mitigating the highest risk areas based on the pathology and anatomical spread of each of the 7 oral cavity apartments.
Now, here is a final provocative thought for you to consider at your next planning session. When optimizing a complex oral cavity plan, if you are forced to compromise one DVH goal, perhaps to meet the CTV coverage, should it be the ipsilateral parotid gland mean dose or the mandible ORN constraint? And why does the specific subsite location influence your answer? Think about the specific ORN risks we discussed for the mandible body versus the ramus.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.